Welcome to this high-yield review of COPD for Step 2. Our goal is to master the diagnosis, gold classification, and stepwise management of chronic obstructive pulmonary disease. By the end of this review, you should be able to confidently approach any COPD question on your exam. COPD is defined as persistent respiratory symptoms, cough and dyspnea, with airflow limitation. The diagnostic criterion is a post-bronchodilator FEV1 to FVC ratio below 0.70. COPD is an umbrella term that combines two entities. Chronic bronchitis is a clinical diagnosis. Productive cough for at least 3 months per year for 2 consecutive years. Emphysema is a pathological diagnosis. Permanent dilation of air spaces distal to the terminal bronchioles, with destruction of the alveolar walls. Both can coexist in the same patient, which is why the umbrella term COPD is useful. The etiology of COPD is divided into exogenous and endogenous factors. The number one cause, by far, is tobacco smoking. Other exogenous factors include occupational dust, chemicals, air pollution, and biomass fuel exposure. The most important endogenous cause is alpha-1 antitrypsin deficiency, or AATD. Think of AATD in a young patient, under 45, with lower lobe emphysema, especially if they also have signs of liver disease like jaundice or cirrhosis. The key Step 2 pearl: smoking cessation is the single most effective intervention to slow lung function decline. Always screen new COPD patients for AATD on initial diagnosis. The pathophysiology of COPD begins with chronic inflammation from noxious stimuli like cigarette smoke, which causes oxidative stress and reactive oxygen species release. This drives goblet cell hyperplasia and mucus hypersecretion, along with impaired ciliary function, producing the classic chronic productive cough. Smooth muscle hyperplasia narrows the small airways, and hypoxic vasoconstriction remodels the pulmonary vasculature, leading to pulmonary hypertension and ultimately cor pulmonale. In emphysema, alveolar destruction causes loss of elastic recoil, which leads to air trapping and hyperinflation. The Step 2 pearl: cor pulmonale, right heart failure from pulmonary hypertension, presents with JVD, peripheral edema, and hepatomegaly in advanced disease. Early COPD presents with a chronic productive cough, dyspnea on exertion, tachyapnea, pursed lip breathing, and a prolonged expiratory phase with wheezing or rhonchi. As the disease progresses, you see barrel chest, hyperresonance on percussion, decreased breath sounds, cyanosis, and signs of cor pulmonale, JVD, and peripheral edema. Advanced patients are often cachectic with secondary polycythemia and may develop confusion from hypercapnia. One important Step 2 distinction: nail clubbing is not a feature of COPD. If you see clubbing, think of other conditions like bronchiectasis, pulmonary fibrosis, or lung cancer. Two classic COPD phenotypes show up on Step 2. The pink puffer has predominant emphysema. They are thin, cachectic, non-cyanotic, use pursed lip breathing, have only a mild cough. Their PO2 is only slightly reduced and PaCO2 remains normal until late disease. The blue bloater has predominant chronic bronchitis. They are overweight, cyanotic, and have a productive cough with peripheral edema. Their PaO2 is markedly reduced and PaCO2 is elevated early on. They develop hypercapnia quickly. Remember, pink puffers breathe hard to maintain oxygenation. Blue bloaters retain CO2 and become cyanotic. There are two main emphysema subtypes to know. Centrilobular, also called centriacina emphysema, is caused by smoking and affects the upper lobes. It is the most common subtype. Panlobular, or panacina emphysema, is associated with alpha-1 antitrypsin deficiency and affects the lower lobes. Remember this mnemonic: smoke rises up. Centriacina disease from smoking affects upper lobes. If you see a young patient with lower lobe emphysema plus jaundice or cirrhosis, think ATD immediately. Spirometry is the gold standard for diagnosing COPD. A post-bronchodilator FEV1 to FVC ratio below 0.70 confirms the diagnosis. Unlike asthma, the reversibility test shows less than 12% change in FEV1 after bronchodilator. This is the hallmark of fixed obstruction. Body plethysmography shows increased total lung capacity, functional residual capacity, and residual volume, reflecting air trapping. DLCO is decreased in emphysema, a critical distinction from asthma, where DLCO is normal or elevated. Always check serum alpha-1 antitrypsin level on initial diagnosis. ABG may show hypoxemia with or without chronic hypercapnia. Chest X-ray shows hyperinflation, flattened diaphragm, increased AP diameter, and hyperlucent lung fields. CBC often shows secondary polycythemia as a compensatory response to chronic hypoxemia. GOLD classification uses post-bronchodilator FEV1 as a percentage of predicted to grade severity. GOLD 1 is mild, FEV1 at or above 80%. GOLD 2 is moderate, 50 to 79%. GOLD 3 is severe, 30 to 49%. GOLD 4 is very severe, below 30%. A simple mnemonic to remember the cutoffs. 30 plus 50 equals 80. Important: GOLD grading only applies after you've already confirmed COPD with FEV1 to FVC ratio below 0.70. The GOLD groups A, B, and E classify patients based on symptom burden and exacerbation history, and these groups guide treatment. Group A has low symptoms, MMRC 0 to 1, or CAT less than 10, and minimal exacerbations. Group B has high symptoms, MMRC 2 or greater, or CAT 10 or greater, but also minimal exacerbations. Group E is the exacerbator group, 2 or more moderate exacerbations, or at least one requiring hospitalization, regardless of symptom severity. Key Pearl: Group E replaced the old groups C and D in the 2023 GOLD update. Frequent exacerbations now carry the highest priority in treatment decisions. Treatment is determined by GOLD group. Group A gets a single long-acting bronchodilator, either a LABA or LAMA. Group B gets dual therapy, LABA plus LAMA combination, for example, ameclidinium vilanderol. Group E also gets LABA plus LAMA, but if the blood eosinophil count is 300 or greater, add an inhaled corticosteroid, making it triple therapy, LABA plus LAMA plus ICS. For rescue medication, all patients use SABA or SAMA as needed. The Step 2 Pearl: bronchodilators are the mainstay of COPD treatment. ICS should only be used in combination with long-acting bronchodilators, and it carries a risk of pneumonia. And remember, no drug beats smoking cessation for improving survival. Advanced COPD management includes both non-pharmacological and pharmacological approaches. Non-pharmacological measures include smoking cessation, the number one intervention, pulmonary rehabilitation, physical activity, and vaccinations. Annual influenza, pneumococcal, and COVID-19. Long-term oxygen therapy is indicated when PaO2 is 55 mHg or less, or SaO2 is 88% or less at rest. LTOT is one of the few interventions proven to improve survival. Surgical options include bulectomy for severe emphysema with large bullae, lung volume reduction surgery for selected patients, and lung transplantation for very severe disease. Only 4 measures have been proven to improve survival in COPD: smoking cessation, long-term oxygen therapy, lung volume reduction surgery, and lung transplantation. Acute exacerbation of COPD, or AECOPD, is a clinical diagnosis based on acute worsening of 3 cardinal symptoms over 14 days or less. The 3 cardinal symptoms are worsening dyspnea, increased cough frequency or severity, and increased sputum volume or purulence. The most common etiology is viral respiratory infection. Common bacterial causes include Haemophilus influenzae, Moraxella catarrhalis, and Streptococcus pneumoniae. Air pollution and environmental triggers can also precipitate exacerbations. Initial workup includes ABG to assess for hypoxemia, hypercapnia, and acidemia, chest X-ray to rule out pneumonia or pneumothorax, and CBC. The key pearl: AECOPD is a clinical diagnosis. Don't wait for test results to start treatment in a deteriorating patient. Management of AECOPD follows 4 key steps. First, oxygen therapy. Target SpO2 of 88 to 92%. Avoid overoxygenation because it can cause CO2 narcosis in chronic CO2 retainers. Monitor ABG frequently. Second, non-invasive positive pressure ventilation. BiPAP is the preferred modality. Indications are respiratory acidosis with PaCO2 at or above 45 and pH at or below 7.35, severe dyspnea with accessory muscle use, or persistent hypoxemia despite supplemental oxygen. Third, bronchodilators for all patients, SABA with or without SAMA, delivered via nebulizer or MDI with spacer. Fourth, glucocorticoids and antibiotics. Give prednisone 40 milligrams orally for 5 days. Antibiotics are indicated if all 3 cardinal symptoms are present, or if there is increased sputum purulence plus 1 other cardinal symptom, or if the patient requires mechanical ventilation. The Step 2 pearl: target SpO2 88 to 92%. Overoxygenation in COPD can reduce the hypoxic respiratory drive and cause CO2 narcosis. Intubation is a last resort, only if NIPPV fails or is contraindicated. Let's wrap up with the highest yield points for Step 2. For diagnosis, spirometry is the gold standard, and post-bronchodilator FEV1 to FVC below 0.70 confirms COPD. DLCO is decreased, a key distinction from asthma. Screen every patient for AAT deficiency. For gold grades, remember 30 plus 50 equals 80. Grades 4, 3, 2, and 1 correspond to FEV1 less than 30%, 30 to 49%, 50 to 79%, and 80% or above. For gold groups and treatment, Group A gets LABA or LAMA monotherapy. Group B gets LABA plus LAMA, and Group E gets LABA plus LAMA with ICS added if eosinophils are 300 or higher. For AECOPD, the 3 cardinal symptoms are worsening dyspnea, cough, and sputum. Target SpO2 88 to 92%, and use BiPAP for respiratory acidosis. Give steroids and antibiotics when indicated. Finally, the classic Step 2 traps. Smoking cessation is the #1 intervention for survival. A young patient with lower lobe emphysema, think AATD. Overoxygenation in COPD can cause CO2 narcosis. LTOT improves survival only when PO2 is 55 or less, or SaO2 is 88% or less. and nail clubbing is not a feature of COPD. Think bronchiectasis or lung cancer instead. Good luck on your exam.